Thank you, Phil, for the kind introduction. It's an honor and privilege to come here, and thank you for the organizers to invite me for this talk. So I'll be talking about retinopathy of prematurity and examinations and the incorporation of digital devices, especially the red camera and images. Okay, so I have no financial disclosures. So this is going to be the outline of the talk. I'll talk about ROP and service in Abu Dhabi, the screening schedule, examinations, documentations, digital images, the treatment that we offer, laser and anti-VEGF injections, the ROP team, which is very important, the roles and responsibilities of each, parents counseling, visual rehabilitation, and then ROP screening in UAE. So the ROP service in Abu Dhabi is divided in two different sites. The screening is done at Cornish Hospital. One part of the treatment, which is anti-VEGF injection, Cornish Hospital, we're very fortunate that we have a dedicated pressure ventilated room where we do the injections. The laser therapy is done at SKMC. Hopefully, we are planning to do the laser therapy in Cornish in the future. Business plan has been sent over, and we're hoping that we can do lasers in one unit. So Cornish, as Dr. Ayman has already said, we have official 64 cots. It is the largest unit not only in Abu Dhabi, but only in the whole of the UAE. The occupancy is quite high, more than 80 cots, and about 25% of the admissions there are less than 1,500 grams, which means that we get quite a load of RFP screening. The screening can vary from 8 to 20 babies per week. And the treatment is about 1 to 2 babies every week, which includes laser and anti-VEGF injections. So I'm just going to briefly touch upon just the guidelines that who to screen, when to screen, and how often to screen. So these are taken from the guidelines from the UK Pediatric Society. So babies less than 32 weeks gestation age and babies less than 1,500 grams birth weight. So when to screen, so anyone less than 27 weeks is 30 to 31 weeks. Between 27 and 32 is 4 to 5 weeks. More than 32, again 4 to 5 weeks. And more than 32 weeks, but less than 1,500 is again 4 to 5 weeks. So 4 to 5 weeks is the easy figure to remember. And how frequently? I'll come to the zones and the stages in the next stage. So we definitely see them every week. These are the criteria for the babies which we see every week. If the blood vessels end in zone 1 or posterior zone 2, I'll come to that in the later stage. If they have a presence of certain activity of the disease called as plus or 3+, and if they have more neovascularization, which is stage 3 in any zone. The screening goes a bit longer. We can see them every 2 weeks if they have no ROP, and we do it until the blood vessels reach the end of the retina, which is called the aura. So we still use the guidelines. These are very comprehensive guidelines. They were published in 2008. American Academy also have their guidelines. They're pretty much the same, but these are the ones which are widely followed. So the zones which we are talking about, this is just a map of the retina. The inner zone, which is the darker bluish, I say, kind of grayish, that is zone 1. It includes the optic nerve and the macula. The macula is the most important part. If your this area gets affected, then the green area is zone 2, which is double the distance of the zone 1. And in the far periphery, the yellow one, that's zone 3. You can see that the temporal retina is more as compared to the nasal retina. That's why when we see babies, they often have avascular or immature retina in the temporal aspect, which is more towards the ear. Now, what are these stages? The stages are divided among the appearance of the blood vessels and where they end. If we have a demarcation, there's blood vessels on the retina, and then there's a sudden stop. That's the demarcation line. This is stage 1. If you have a slightly pink demarcation line, which shows the presence of some tiny, minute blood vessels, that's stage 2. Stage 3 is not good. It shows there's vascular proliferation and there's a formation of new vessels. The last one, stage 4 and stage 5. If you see this, it means that you've lost your game, and unfortunately, these are difficult to correct. Stage 4 means that they have a retinal detachment. It's further divided into 4A and 4B, which means that it involves the center of the eye called the macula. 4A does not involve, 4B does involve, and 4-5, when you completely lost the game, the retina is completely detached. Now, what is the plus? Sometimes if you look at our nose, we say presence of plus or pre-plus. That means how tortuous the blood vessels are. Are they very tortuous? Are they dilated? If the pupil is small and if there's vitreous haze, they all show the activity of the ROP, the disease activity. So if you come across an ROP note which says this, that means the baby is not doing well. Obviously, it's difficult to recognize all these findings as a neonatologist, but if you come across these notes, that means the baby was not doing good. Now, when to stop screening? So babies who never develop ROP and the blood vessels enter into the far periphery, which is zone 3, even midway, usually happens just about 36 weeks or onwards. We can stop the ROP. This is when they have no ROP. Babies with ROP and they have no increase in severity in 2 visits, there's a resolution of stage 3, you can stop it. But especially those babies which are post-injection baby, because nowadays a lot of neonatal units, lots of ophthalmology units, or the ophthalmology colleagues, they are using anti-VEGF injection, which I'll talk about later. These are the patients which require longer examination, longer screening, especially if they have an avascular retina. So they will be discharged from your units, but they need to be followed up by an ophthalmology unit. All right, now this is our neonatal unit in Corniche. It's quite a busy, stuffed up place, and this is just a few clock hours. Can anyone guess how many babies were there? So there were 6 babies in that small sweep. So going through there and managing yourself, so I had to lose about 10 kg to fit into those areas there. It requires a lot of acrobats to see the babies and move the carts around, but we've managed well. So. All right, so now the next part is documentation of the clinical notes and the EPR and the images. So we're quite fortunate for the last year, we were able to document all our images onto the electronic patient record. The neonatal unit in Corniche, that's my favorite unit. They are very progressive, and thanks to all the department staff, we were able to now draw images onto Cerner directly. So you can see previously they were all papers and pages. Sometimes you cannot see the pages are missing. And now we have the facility of uploading the retinal images directly onto the patient's records. So when I see this patient in the clinic, I don't have to go through the RedCam. I have the images there in the Cerner. So again, documentation is extremely important, because if a patient goes wrong, it also serves as a legal document. You have pictures and images, which is very helpful. So this is how we do it. We have the basic information, the gestational age, the corrected age, the birth weight, and current weight. And this is the diagram that we draw, and the rest of it is a normal ROP sheet, which states the zone, the stages, and some of my documents down over below. Okay, how do we, so the examination is usually done at the bedside in the cot. We use dilating eye drops. Usually the nurses are quite good. They dilate the babies 1 hour before. Some units are different. They use, can you please take that? Yeah. Some units are different. They use tropicamide, which is still the same. We use 0.5% and phenylepinephrine. That's a different presentation that you've found. You just need to select the different screen. Yeah, I think we're already in a meeting. If you It's good over here. So I have the slides over here. So okay, great, good. So we're talking about the dilating eye drops, and we use local anesthesia and use a lid speculum and an indenter. We also have sucrose if it's available. Then we use that. Right. Next slide. So talking about the when to treat. So if we have a baby who is in zone 1, stage 1 and stage 2, and presence of plus disease, definitely this baby will get treated. We'll talk about either laser or anti-VEGF later on. If the baby is in zone 2, zone 1, and stage 3, definitely, irrespective of having plus or no plus, that will get treated. Zone 2, stage 3 with plus disease, that will get treated too. Excuse me, can we minimize those the windows there on your right hand side? If you just click on the tiny tab, they can go down, so at least everyone can view the full screen. You just need to minimize this. Yeah, that's it. Thank you. All right. So if anyone is zone 2, stage 3, and plus disease, definitely they need to be treated. I've lost my control here. Oh, sorry. Okay, that's right. Okay. Sorry, guys. So this is a treatment room that we do for the anti-VEGF. It's a dedicated room. It has a positive pressure ventilation. There we have the red cam, so all the images are taken before. The good thing about having a image device is that parents want to see, because the external eye examination would look as normal as any eye. They're more interested in looking what's happening inside the eye. So these images, you show the images to the parents and they understand what is happening. So we get the bed, the cot inside, and we just remove the top cover, the side cover, and we do 2 eyes at the same time. We scrub independently for each eyes. We do have a neonatologist there, just if the baby desats at that time. We also have a respiratory therapist at that time, and we also have a nurse. It cannot be done alone. Don't try to do it alone. Don't try to let the ophthalmologist do it alone. They need some support from you guys, and especially if they're doing the anti-VEGF injections inside the facility. Touch wood, we've had zero infection up till now. Some of the babies who require laser treatment, they are transported from Cornish to SPMC. The transport team is fantastic. There are 2 team members from Cornish, a nurse and a neonatologist. Babies are usually intubated and they go back intubated. The round trip is about 2 to 3 hours. There are days in which we've done 2 treatments at the same time. So let's talk about laser. This is the laser machine that we have. The laser machine is present in SKMC. It's a green laser. There's no cutting involved with it. So when I tell the parents what kind of treatment it is, we tell them that it's a laser treatment. It's there to burn the retina. So it's some kind of some quite reassuring for them that we're not doing any cutting. And usually one treatment takes about 2 hours. Both of the eyes are done at the same time. This for Cornish Hospital in 2000. I have data for other years too, but this is the slide which I have. In 2019, which we were quite busy during COVID, we screened 880 babies, and we treated about 32 babies at that time. So just something about the laser versus the anti-VEGF. A lot of the neonatologists, they think that the anti-VEGF has completely replaced the laser. That unfortunately is not the case. Yes, you buy time when you're injecting someone with anti-VEGF. Buying time means is that the retina gets a chance to develop a bit. So if I do laser on the top bit, so this is an avascular area. If I do laser over here, this visual field will all be lost. So the kid can still see from the optic nerve and the macula, but the peripheral visual field is lost. By doing an anti-VEGF, the same thing. Sorry. With the anti-VEGF, there is a chance of the retina to grow. When the retina grows a bit more, so you have more useful sight vision. But it doesn't solve the problem there. It's still very important for all these patients who've had anti-VEGF injections. They need to be followed up because there are some areas of avascularity in the far periphery which need to be lasered. So it's a fantastic tool to have, but again, laser is still required to finish the treatment sessions. Again, just the difference between laser and anti-VEGF. Again, laser is a long procedure. It requires 60 to 90 minutes. It requires a certain skill, certain technique. Not many ophthalmologists are careful, are skillful to do it. It takes a while. That's why the anti-VEGF has taken on a lot of success. Again, it's good, don't get me wrong, it's fantastic. I like it, I will do it a lot. But again, they need to have the laser later on. So yes, it causes some certain stress on the cervical spine because that thing which goes on the head, this thing, it has some considerable weight. The headlamp, it has some considerable weight, and if you have that for 4 or 5 hours, your neck starts to hurt. By doing laser, of course, you are causing some myopia. All these kids who have laser, the front part of the eye grows, the area which has had laser does not grow. So there's an imbalance between the front and the back eye. That gives rise to myopia or short-sightedness. So all these kids will have good vision for near, but after 5 or 6 feet, when they're 1 or 2 years, they will require glasses. Any kid that you see in your post clinic or your pediatric clinic, if they've had laser, if they should have an eye check. Anti-VEGF injections, of course, because the retina is growing, they cause less short-sightedness. But the problem is the recurrence of ROP is definite. It's a quick procedure. You don't need a GA. It can be done under LA and sedation. Now, the other thing is that the anti-VEGF injections, they are delivered inside the vitreous. They do cross the blood-brain barrier. They can reach to different blood vessels. They can cause thinning of the blood vessels. This injection has been out in 2005. These kids are just about 15. No one knows what's going to happen when they're 40. They'll have very thin retinal, like blood vessels. Are we looking at early strokes, early ischemias, anything at all? We don't know. So it's all right. I'll just skip this case. This is just a few cases that we've talked about these cases. Let me just go on with the next one. Okay. So the most important thing is the retinopathy of premature. I mean, the roles and responsibility are very well. The RP nurse, the ophthalmologist, the neonatologist, and they follow up the discharge sheet. These are the most important things, because I think your ophthalmologist will be on board. And need to be kind of well informed and kind of remind them that how many babies and the dilatation and all this. And your RP nurse should be the same nurse every week. We have 2 nurses, like 1 week we have, but they know our routine, the schedule. They know pretty much everything. It's very important. Follow-up is very important. These kids, they do develop strabismus, which is crossing of the eye, and they also require corrective glasses. There are some information sheets. So if you this is a QR code, this is a fantastic information sheet from the APOS. This is something nice for the parents. You can give them. Artificial intelligence is really coming up, and with the digital images, there is a program where we probably will be in joint venture with an AI professor in the UK. We'll be sending them images, and but you need a massive amount of data. They have to be this of a particular quality, and the light, the megapixels and all that stuff. So they can predict that if this baby is going to be requiring a treatment or not. That's it. Thank you very much.